Welcome, everyone. I'm Dr. Jessica Seaman, Assistant Dean for Faculty Development in Creighton School of Medicine. Thank you so much for joining us in person and virtually for a professional development session, Excellence in Clinical Practice, presented by Dr. Kaiser Lim. I have a few housekeeping items before I introduce our wonderful speaker. This session is being recorded, and you will have access to the recording and slide presentation for future reference. We invite you to ask live questions or submit them in the chat, and we'll get to as many as we can by the end of his session. For those on Zoom, we do ask that you remain muted with video off unless asking a live question, just to assist us with the recording. Also, this session is eligible for CE credit, and you'll receive the website and activity code before we conclude. There is a short survey associated with the continuing education, and we thank you in advance for providing feedback for us as we continue to bring you diverse and robust programming here at Creighton. Now to introduce our speaker. Dr. Kaiser Lim is Medical Co-Director in the Pulmonary Function Lab at Mayo Clinic in Rochester. His responsibilities at Mayo over the past 23 years have included directorship of the Asthma Clinic, Director of the Pulmonary Inpatient Practice, and founding director of the Chronic Cough Clinic. And as a side note, he shared his knowledge around chronic cough with the Creighton community just last fall, and we appreciated that session from him. Dr. Lim is married to a neurologist and has 3 children. So, Dr. Lim, if you're ready, I'll turn the time over to you.
Thank you. So, people say excellence in clinical practice, and what does it mean? Because aren't we doing an excellent job? Aren't our evaluations great? It turns out that there's a lot going on, and it has to do with definitions, and it has to do with how we move forward. And I thought I'd share an overview of health science management as it applied to clinical practice to improve it. And it's important to understand that we're doing this to empower clinicians so that when you look at your workflow, you will say, aha, we can do better. Aha, this is where the problem is. You won't feel like you're helpless. You won't feel like you're subject to the whims of other people who don't know what the heck you're doing. And just like what was discussed earlier today, it offers a pathway for you to stay engaged and passionate about your vocation. Because nothing is more demoralizing than when somebody uses a yardstick, which is totally different from what you're trying to accomplish. And so I hope that by the end, you will have an overview of where to proceed. This is such a vast field, and I don't think that short of a 3 to 6 month time period, you would acquire the skills. But this is kind of like a look through the window. So in terms of the discussion, we'll be talking about excellence in healthcare and outcome, aligning priorities, explaining why there is a discrepancy between priorities. We're going to talk about how you can achieve and learn implementation science. And then we're going to provide you with a conceptual framework so that you could start categorizing how you improve certain projects, whether it's to improve the functioning of your clinic, whether it's to design a new service line, whether it's to introduce new technology. These are templates that you could use. So excellence in clinical practice has to be defined because excellence, we know, means high quality, but what are we measuring? We should be measuring patient outcome. This is the ultimate reality for the patient. To the point that you have this popular equation that is now being used by the government and other healthcare organizations. They say value care, high value care is related to patient outcome divided by the cost. The guy you blame this equation for is Michael Porter and Elizabeth Teisberg. This is their 2006 book. I actually love it. And it was very insightful. Here's a Porter light type of take on the subject. The problem is that there's a lot of vagueness. What exactly do you mean by patient outcome? For example, patients think of outcome as my health is restored, my function is restored. For physician, you think, oh, good diagnosis, timely, cost-effective, treatment is safe, good risk-benefit ratio. The administrator is thinking, oh, aggregate data. How's my access? Is it a high-value care? Are diagnostic tests being utilized properly? Is it safe? Are we compliant with regulatory standards? And from society's point of view, are we ensuring safety? Is there equity? Are we working enough on prevention and early detection? Because nobody pays us for prevention. And early detection is really hard to prove. So, for example, in diabetes, look at patient accountability and agency. Patients are active participants. So when you're looking at outcome, it depends on what they do. If their BMI is 50, they don't want to lose weight. They can't say no to the carrot cake. They don't want to do their glycemic monitoring. The accountability becomes a bit of a challenge. And then they say there's a Kaiser Permanente paper that says, if the hemoglobin A1C is 9 and above, you blame the doctor. If it's between 7 and 9, you blame the patient. And CMS has taken it to being a rule. But guess what? You're under the care of Dr. Taylor for 20 years. He checks hemoglobin A1C intermittently, never acts on it. You're a young person, you step in and you inherit this patient and they're all out of kilter. You send them to nephrology, proteinuria was not picked up. End organ assessment has never been done. Their cardiovascular risk has never been done. Whose fault is it? So when we look at clinical outcome, as clinicians, we look at time to complication, survival. We never talk about independent living and wellness at the end of the patient's lifespan. And most of our governmental outcomes are surrogate outcomes. They are process of cares. How often did you take your hemoglobin A1C? How often did you check their cholesterol? Whether or not you get the cholesterol has never been monitored. And so when we're looking at these things, you're saying, okay, that's a mess. But there's another bit of a mess. It's the patient's attitude. So health outcomes. Patients are more worried about symptom relief. They want no complications, while the doctor is more worried about diagnosis, therapy, complication. Patients are worried about process of care. They want convenient access, and they want a competent caring physician as if everything is a given. For physicians, we worry about competency matching. We worry about in-basket support. And for costs, they worry about out-of-pocket. They don't see the reality as long as the insurance pays for it. And you'd be seeing patients without asthma on biologicals for asthma because of wrong diagnosis. But the patient feels that the doctor is doing great. He got me a good drug. And then finally, psychosocial, they're expecting empathy, affirmation, you're friendly, you listen to them. But for physicians, we're worried about work-life balance. You want your organization to appreciate what you're doing. You want your peers to say, oh, Kaiser does a good job. And all these priorities don't align. That's why you ask yourself, why is there a disconnect? And this is a fundamental concept. And it's not people being mean. It's not people being ignorant. It has to do with knowledge asymmetry. 3 people got the Nobel Prize for this. And this is a fundamental concept because in knowledge asymmetry, we're in a collaborative situation wherein one party has no idea of what you're doing. They don't know if your treatment is elegant or it is convoluted. They have no idea of what you mean when you say, well, it's statistically not significant. So these conceptual and methodological differences causes the patient to look at us differently. So this information asymmetry is best compared to a used car salesman and a buyer. So adverse selection means that you don't know what is best. That's why patients during this patient satisfaction, they rate us for the hotel services, what they see. It leads to opportunistic behaviors. Has anybody heard the Dr. Death podcast? It's making its rounds, and that's a reality. That's why you have a grand piano in every major hospital because they are now sprucing it up for that externality. They're signaling to patients that we are a lucrative, high reputation organization. And sometimes that leads to moral hazard. Patients don't choose doctors. They don't do their homework. They just go to anybody and they expect to get well. The way we balance this is with trust, the assumption that doctors will always do what's best for their patient. There's transparency. We work on reputation and you have to communicate, but this doesn't always work. So what does it mean when we're looking at patient outcome? It has to be a multi-dimensional assessment. So that simplistic Porter equation is not going to be something that you could carry out in any type of evaluation. It's a theoretical framework. It's a good one, but very simplistic. So we introduce implementation science because how do we get to the kind of outcomes that we want? There is a methodology to this, there is science behind it, and there's clear pathway for you to achieve it. And this is different from the clinical research that we usually do, the basic science that we try to encourage, the educational pathway. This implementation science allows us to have a better life in terms of seeing patients. One of its aim is to address gaps, identify them, fix them, sustain them. The other one is to translate research findings earlier. So the first cholesterol guidelines came out in 1988. As of 1998, only 40% of Americans had cholesterol measured. And when you think about these gaps and these discrepancies in every one of your field, you know that there is such a lag time. And so as part of excellence in clinical care and practice, you're trying to accelerate that. You're trying to move it forward because these are research findings that make a difference, short-term or long-term. Now, you will see that the number of papers that are coming out, this is a meta-analysis from the surgical field. They start looking at outpatient, OR, and inpatient quality. And what's very important about this is that it's bite sizes. You're not taking on the whole system. You're looking at a very specific step, and then you say, this is what we need to interfere with. This is where we intervene. And it's acquiring that knowledge to say, this is the keystone. This is the crucial portion that is important. And in radiology, they're already doing that as well. Medicine has a lot more activities. And the problem is that it's like a tsunami of findings. And they come out in different journals. They don't make it to the journals that you and I normally read. They come out in the Journal of the Joint Commission. They come out in Quality and Safety. How many of us read those unless you're doing this as a career? So what I hope is to talk about how you can acquire this knowledge, what kind of analytical tools and knowledge is being used, because when you're being approached for a project, at least you know what they're trying to say. Acquiring the institutional network and contacts. There's no textbook for this. So in the various projects that I've had the fortune of being a part of, you learn who the key players are. And sometimes you go through the regular process, middle managers will say, no, 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 until you just pick up the phone and you say, Mark, this is what's happening. And Mark will then suddenly send out an email and suddenly everything is possible. You want data? And I don't know if Scott remembers, there used to be the chief accountant. Her name is Elaine Shimbari. And an email to Elaine, within 3 days, 4 days, you get your data. And then she retired. And then I'm lost because I don't have data anymore. And then it also needs a little bit of reflection, because like leadership skills are necessary. So for example, you can have the coercive, wherein it's a crisis mode. This is the way it is. If you have more time, you can be a coaching, a democratic type. So there are different types which we won't talk about, but you just have to be aware that as you're going through projects, you may have to be more flexible. And finally, there's the nuts and bolts of a project management skill that you have to acquire. And I'll show you some of this and use some of my projects as examples. So first option, of course, is how do you acquire the knowledge? You go to school. The Department of Medicine under Nick LaRusso thought that several of us need to go to the Black Belt Leadership course, sent us over. There's actually more formal training. I actually was admitted to the Northwestern based on a scholarly clinician grant. I never made it because we had no off-campus learning at that time. The second is to get engaged. The background is the CMS. The foreground is JCO. And there are literally dozens of projects. And so when you are approached by your chair and they say, we're going to do something, JCO is coming, we got to work on this. If you're interested, volunteer. Because once you learn how to think, it's a mindset. Once you acquire that, you find out, I like it, I don't like it. And then you can invest and say, do I want to go back to school, get more skills? Do I want to do this as my career? So if you look at my publications, half of them are in quality improvement. And it's not quality improvement to make the institution happy. It's quality improvement because I think it's important. And so the conceptual framework, as you're thinking about projects, is what we call operational excellence. No-show rate. If 50% of your no-show rate in clinic is going to destroy your clinic, you better find out why they're not showing up. Is it because the referrals coming from the ER? These are transients. Is it because your clinic availability is 6 weeks down the line? Then there are lean projects wherein you're trying to improve the performance. Think of an organization as a garden. So during this season, you plant things and you expect them to bloom. Next season, they stop blooming. What is a flower that does not bloom? It's weed. So when you're reconciling things that were done in the past, because you've never reconciled the rules that were set for previous project, you're weeding. And it's a constant weeding process. And there's a rationale for this. There's innovation when you want to start new service lines. I wanted to start a chronic cough. I wanted to introduce rhinoscopy. I want to introduce exhaled nitric oxide. All these service lines had never existed before at the Mayo Clinic. And so how do you do it? Human resources. Oftentimes, the expertise comes with training. So you want somebody to be able to do endoscopic guided ultrasound. You're an old practice. You either go and do the course or you bring some young person in to teach you. You want somebody to do pulmonary hypertension. Well, how do you start? You have to go get somebody who is a pulmonary hypertension clinic. But the right person to do this has to do with how you pick and choose your candidates. So if you think about it, this is about opportunity, problem solving, identifying gaps, and a talent search. So for me, this type of work is very fulfilling and it's very exciting because at the end of the day, you're really making a difference. People may not know who you are. They just know that such a system exists. But that's the fun part. Now, oftentimes people get carried away with improvement. So for operational problems, these are incremental or evolutionary. You don't need a team. You just need a group of people who are involved. You just do it. Because the minute you start going into this Six Sigma and redesign, you're overcomplicating things. That's why this paper entitled Six Sigma, Not for the Faint of Heart, is to tell people, look, if you want to kill a chicken, you use a cleaver. You get a huge axe for it because you're going to be wasting your resources. You have to match the problem and the solution. So lean projects are the ones that get more attention. And lean thinking is what you're going to be reading in the literature. It's a culture of continuous improvement. Yeah, that sounds great. But what does it mean? At Mayo, we have groups of people who just do this. So when one of my colleagues, Andy Limper, who was briefly in charge of the current center, asked for, please submit the projects that you have done. He had over 100. These are unfunded projects. People just got together and they were doing it. It's a culture of improvement. And you want that for your organization. You want people to be looking out for it. You don't want it to be top down all the time. You want people to care enough so that they do something, and you have a lot of people trained in terms of how to do it. You create value, you have a unity of purpose, you want what's good for the patient to come first, you respect people who do the work, you engage them. And so lean thinking is more of an attitude. Now, this is the worst slide ever. And this is the Toyota way. And let me tell you, we're not a manufacturer. we don't deal with pristine parts. We're more of a used car, a car repair shop, right? They come in and they say, yeah, the rear wheel goes. Every time I start, if I go 60 miles, this happens. We don't have pristine parts, but conceptually, it is useful. But the question is, will you know it when you see it? Because this is all couched in manufacturing lingo. The lingo really buries this. For example, excessive transport. What does it mean? Well, Henry Ting, who's one of our cardiologists, who's now VP of quality for Delta, walked a patient requiring primary angioplasty from the ER to the cath lab. It was the length of a football field over transport. He recognized it. Excessive inventory. Aside from stocking your central supply with too much thing, prolonged length of stay, specialty unit with extra capacity. So when you go down this list, you will find out that it does apply. So for example, you bring them in, they're short of breath, but your echocardiogram is 3 months away. You find somebody with pulmonary hypertension, you have no availability until July. And so all of these lead to inefficiency. And what's important is that if every one of us or some of us in each of our divisions and departments have an eye out, this culture of improvement will get us to where we want to be. We'll never get there. This is a moving, dynamic picture. And that's why all of these lead to what Dr. Porter is talking about. Here are themes: co-localization of resources. Radiology is always in the basement, right? So ENT practice. How do you make a diagnosis of chronic rhinosinusitis? You need a CT scan. The scope picks up 4 out of 10. The questionnaire is less than helpful. And the CT scan is the gold standard. Would you park a Zoran in their clinic for point of care testing? And then you work out who reads it, who gets the revenue, who does the safety, who runs it. Co-localization of services and expertise. This is something that I really cherish. One of my role model is Ruth Johnson. Started our breast clinic. It's one of our most successful interdisciplinary group. You come in, get your mammogram. If the breast tissue is too dense, automatically you get an MRI. You get a biopsy, pathology will read it. They call you as soon as the reading is done. If you need surgical consult, it's an interdisciplinary. They do over 10,000 patients, and Ruth has successfully handed it off to 2 or 3 other people, and the breast cancer is so integrated. And one of the first things I did when I wanted to do a clinic was to interview them, because it forms a template. Interspecialty cross-pollination. You know, when you're looking for a mentor, it doesn't have to be people who do what you do. Some of my mentors were from GI. I've mentored people in ENT. And when you have that interdisciplinary mentorship and collaboration, which is one of the aims of this session, you end up enriching your practice. And so the other thing is algorithm-driven protocol. I have a funny story. So we approached the different practices. We said, you know, you do spirometry and you order a bronchodilator response. Did you know that out of 5,000 something from Dartmouth, only 3% were positive? So we said, you know, if the baseline is normal, we're going to cancel the bronchodilator response. And we went to the bone marrow transplant group and said, oh, sure, that makes complete sense. Let's do it. We went to the pulmonary group and they took us apart. I want my bronchodilator test. You do it, but you do what I order. Don't touch my So we have an algorithm with specific clinic buy-in, wherein we deliver care that is cost-effective and try to eliminate waste. We're not always successful, but doesn't keep us from trying. Standardization of basic care. When you go to primary care, your health maintenance. So for example, I just got an email from our person who is in charge of questionnaire. He says, how often do we send the asthma control tests to patients? Do we do it once a year? How about the mild, moderate, and severe? Do we do it at every encounter, even though it's not asthma related? And you know, people get mad at you when you do that because you end up with 16 pages of questionnaire that's totally irrelevant. So when we were doing our asthma population management for Rochester, one of the pushback was, I just want my oral contraceptive prescription. I don't want to hear about asthma. And so standardization of basic care, what's the setting? Who do you monitor? Do you have a disease registry? Even these will inform your practice. So the big thing that people talk about is the Six Sigma. It sounds so sexy, you know, Six Sigma. Essentially, it's what? 3 defects for every million unit that you create. So 6 standard deviation. And people have mythologized and tried to promote this as the be-all and end-all of quality improvement. And people talk about define, measure, analyze, improve, and control. So the DMAIC, I'm sure you've heard of it. Definition means you say what, you find out what the problem is, the goals are, and I'll show you further what it really means. You get data so that you're data-driven. This is the analytics so that you find key pieces. You design an intervention and monitor. And then if it works, you make it your standard operating procedure. Sounds simple, right? Remember what I said? It's not for the faint of heart. Because how do you define? You have to have a project charter. You have to have a scope of project. You have to specify your outcome. You have to get your stakeholder. You have to have a steering committee. You have to have resources. Can you imagine going to IT and say, I want a report every week? You have to have a project manager. You have to have timeline. And then you have to worry about scope of practice. Something simple like, let's have an ultrasound guided art line placed. And you find out that RTs are not allowed to use ultrasound. Nurses are not allowed to do certain things. And then you have to align with your enterprise strategic goal because that's where you get your resources. If your institution has mapped out something, and here you are from the grassroots, you're saying, hey, listen to me. You're not going to get heard. And so Six Sigma and this type of a project is going to require resources. If you don't get the resources, you're not going to do it well. It's an exercise in frustration. So for example, one of the things that we wanted to do was access. So we looked at days wherein appointments were available. And you will notice that there's a spike. That first spike happens in April and May. What happens in April and May? Spring break, the American Thoracic Society meetings, and that's when everybody leaves. So your availability immediately, you know that this is the time period that you need to work on. You don't have to worry about Christmas. It's not too bad. You have to worry about what happens when the kiddies want to go on vacation with mom and dad. Volume. If you have one doctor and your demand is high, the wait time is going to be high. What happens when you put a second doctor in? And this is where you look at your volume. COPD back then had 1,800 patients. Given the template that we have, that's 1.5 FTE. If you look at cough, we went from 250 patients to 1,200. We're up to 3,500 and more. So your staffing is going to depend on your clinic volume. So what does Six Sigma do? It gives you the data to plan. What kind of people do you put in clinic? The x-axis is the volume. The y-axis is the complexity. We call it process variation. That's how they talk. It's not my language. So if you have high volume, low complexity versus low volume or low complexity, then what's your staffing? You do an e-consult, right? It's easy. Not that many questions, not that complicated. Send me an e-consult. It's better than a curbside because that person has time to sit down, look at the CT scan, generate a documentation. If it's high volume but low complexity, you can put an APC there. If it's high volume and high complex, due to coordination of care, comorbidities, and multi-system disease, you better design a team. So by understanding the problem, by being data-driven, you can have a more rational approach to solving the problems. So people look at benchmarking. Remember the surgeons, they were trying to find out what the wait time is, the OR time. You benchmark it. So for example, I can brag and say, bariatric surgery at the Mayo Clinic, our Roux-en-Y, the national average for a leak is 4.7%. In the last 5 years at the Mayo Clinic in Rochester, 0. So you benchmark your quality against the national norm. You have checklists. Everybody has a checklist. Sometimes checklists will have checklists. And then you look at flow charts, focus interviews, and you look at what we call usability evaluation. So what does that mean? So you essentially map out the steps and you analyze and you say, okay, what's wasted? What does not add value? And what are the solutions? So for example, you're looking at patient differentiation. Self-refer, network, out of network, international, because if it's international, 10% international, you better have a very robust language service. Your EMR has to be compatible. How do you communicate? We say, oh, it's in Epic Care everywhere. Well, not in Saudi Arabia. How about the coverage agreement? Then you look at the payer mix, private insurance, Medicare, Medicaid, self-pay. That's why the discussion of St. Vincent makes a lot of sense because your care model is different. Affordability, revenue stream, how is it going to be funded? Because if this is charity, you know that it's going to depend on development funds. Then you look at acuity, because based on the acuity, is this elective 24/7? How do you prioritize? Indication is disease-specific or symptom-based. Disease-specific, they walk in. I have lymphoma, tissue, confirm. I have a lump. I need to find out what the lump is. Workups are different. Complexities are different. Staffing is going to be different. There's going to be more symptom-based than there are disease-based. And then, so when you're redesigning this, you say, okay, here are the patients. I want to enrich the external self-referred, because this is the national reputation. I want to make it priority so that if a doctor makes a phone call and say, I'm sending my patient to the Mayo Clinic, high priority. The Mayo Clinic health system, Mayo Clinic Rochester consult from other department, our internal pulmonary referrals. there's a pre-visit information. For us, they show up, no CT scan, they're not on care everywhere, no fax data. You're looking at the patient and you're saying, okay, endobronchial lung volume reduction without a CT scan. Brilliant. And he just had one 2 weeks ago. Pre-visit education. We send out a brochure because when people come in for a chronic cough, they don't know what to expect. You want to do a lung function testing? They're like, oh my God, this is something serious. You order tests to facilitate in subspecialty clinics or your annual checkup. You have a standardized history so that you can have templates so that you don't die of documentation death. So for example, you were talking about resident time. So we calculated that our chest inpatient service, our residents spend 3.5 hours on the computer documenting. That's not learning, that's clerical work. This is the value added step, the physician synthesizing, not the physician gathering data. You can see how at each step you've just broken it down. And is it resonating with your own practice? How often do you have to go look for things when you assume that it's gonna be there? And then you come up with a customized care plan, which is the patient's motivation, right? That's why they're there. The rest, you have to have an educational process, video on demand, face-to-face, depends on the patient. Some elderly patients don't do technology. You have a communication, your after visit summary. Have you thought about that as a way of explaining? I had a private doctor talk to me and says, yeah, patient came back and thought they didn't benefit from seeing you. And I said, you know, that was a 2-page summary I gave them. And she said, yeah, they felt that the Advair wasn't working because they couldn't afford it, and they never got back to me. Well, I said, how about the vocal cord dysfunction that we saw? How about you print it out, you hand it to them before they go? That's one of the process of cares that you can do. You discharge them from clinic, you schedule them. Asthma virtual 1 month, they do the ACT, they ask if there's trouble with the medications, they ask how they're doing. And so you have a follow-up that's not heavy on you. You can see that with the EMR, you really can do this. You really can give good care without killing yourself, without missing your kids' baseball games. And when you do this right, you can deliver high quality care and still be the kind of physician that you want to be. You just have to have a process. So for example, you start a clinic, you have patients come in, you do medical management, right? Pitch it for radiology, they go to procedures, and then they come back. Guess what? If you have a 10% return in a consultative practice, at the end of 3 years, you'll have no room to see new patients. So you always plan for the downstream, and that's what the data will do for you. Process mining is a beautiful thing if done right. So for example, the typical encounter is a consultation, diagnostic test, see the patient back, and then you have therapy. Now, if this is a thoracic surgical practice, you see the thoracic surgeon, they get surgery, they come back for their post-op check. Lung cancer is staged, they get XRT, chemo, and then reassessment, right? You even have time. So between the surgery to the second visit, what's the average time? Between the completion of the XRT to chemo, what's the time? Because then you can pan the pathway. You look for fidelity. How often is this pathway violated and why? Are there common exceptions you can plan for? So your pathway becomes a living process. It's flexible regimentation. And so when you start thinking and acquiring that mindset, and you're constantly tweaking it, little tweaks, little tweaks, little tweaks, eventually you get to a place wherein you're able to do all this seamlessly. So for example, with our chronic cough, you say, well, how do you know you're doing better? I would tell you that 90% of patients get better. Not only that, the number of referrals dropped. The one on my, well, it depends on what side I'm facing. The one on my right are people sent to general internal medicine. The one on the left are people who came in through the cough clinic. The number of consultation, allergy, ENT, GI, drop all the way. So what's the unintended consequence? You create capacity for the other services. Itinerary completion. People come to the Mayo Clinic, they pay for hotel, they pay for food. We want to make sure we get them out the door with a good solution as soon as possible. This should have been a geometric mean. Cindy wanted to conflate the result, but you can see the difference. Cost savings. Statistically, we were doing less methacholine, less CT chest, less CT sinus. And if you look at all these procedures, it's actually less. Better care, more cost effective, cheaper. So to add to your reading list, because we're dealing with people, guys. These are people. You have to share your vision. You have to be like a virus. You got to go infect them with your enthusiasm, with your drive, and people will come and they will give you their ideas. They will say, Dr. Lim, what about this? And it becomes a teamwork. It's not me or you, it's us. And that's what you want to foster. It's that culture. So made to stick is really funny. So we had him come to the ACCP and he said, the best way to stop Gen X people from smoking is to let them know that 90% of people on Match.com will not date a smoking person. Influencer is a great book because it opens with how the Thai Ministry of Health managed to get HIV down in its army recruit. First thing they did was to educate. That's the first thing we want to intervene, right? We educate. It turns out that nothing happened. So they approach the brothel and say, if there's anybody with an STD, I'm going to shut you down because you're not using condoms. And so all the brothels in Thailand started using condoms and everything went down. You find the behavior that's responsible. It talks about how the Carter Center is putting a dent on guinea worm infection. Case studies of what you do. Identify the key behavior. Design something that will structurally and functionally change that behavior. And then it will be self-sustaining. So we didn't talk too much about the network, the leadership, and the project management skill, because these are more specific and a little nebulous, because how can I teach you to be friendly? How can I teach you, what goes beyond a handshake? So you think about this conceptual framework when you're thinking about project, because it'll tell you the scope, it'll tell you how much resources, it will tell you the context. So let me run through some. Specialty boutique, you require specialty knowledge, unique diagnostic assessment, unique therapy, you have better outcome. You will have to invest in human resource and you have to have a pathway for innovation. If you want to introduce a new diagnostic test, you not only have to have the equipment, who's running it? How do you get it into Epic? If you want to do a care pathway like the breast clinic or the thrombophilia clinic, how do you design it? So we tried to do the thrombophilia clinic, and one of the reasons why we had a rocky start was because we weren't allowed to do point of care testing. What's the PT? What's the INR? You still have to send them to the lab. And then for clinical decision support, before you start creating algorithm, and we were talking about supplanting the pulmonologist with an AI who will read lung function at least 85% of the time accurately, you have to have the resources to be able to do this. So you do lean, you do innovation, you have to have the right people. To start a clinical research unit, you have to have the patient, you have to have industry's sponsored study to pay the bills in between the lean months, and it will require some of these tasks. So in essence, I've outlined some of the things required for boutique practice, and you start looking at the data and you start mapping things out. And at the end, you will have a boutique practice. It's not haphazard. There's a science to this. And if this is what tickles you, gives you life, makes you want to come to work in the next morning in spite of everything, then you should pursue this. So we always talk about our desired outcomes. How about our unintended outcomes? So for example, when you're looking at reimbursement, so we introduced Excel nitric oxide in 2005. Blue Cross Blue Shield had a technical bulletin saying it's experimental. And for the next 7 years, it was an argument. You have to have form letters. Right now, E&O in asthma is considered standard of care. Cough Clinic went from 250 to over 3,500 a year. It's overwhelming us. And how do you scale up? I still don't know the answer. And then unexpected associations. So you started seeing dyspnea, but then you need hypertension. You need different types of technology. You need cardiopulmonary exercise testing. And so it's going to lead to downstream bottlenecks. Sometimes patients come with unrealistic expectations. The worst statement that you will ever hear is, Dr. Lim, we Googled you. I was like, okay. And then you realize you're in trouble because, look, you can never meet expectations like that. Scott, do you have something to say? Yeah. So finally, we'll talk about innovation projects. These are hard, and it requires certain types of setting. You have to have the volume and the expertise. You have to have in-house expertise. How can you do machine learning if you don't have people in informatics? You also need to give clinician time. If you're so busy seeing patients, you're not going to have time to think about these things. And then it's important to have an organization wherein you put your bet in one basket and it didn't work out. It's like, boom, persona non grata, don't ever come back. It's okay to fail. We don't have crystal balls. Of course, you want to make sure that the upper and lower limit of failure have been defined. It's not a $50,000 failure, right? And finally, you have to have the data analytics and the support. Otherwise, you're flying blind. So here are some of the challenges that confronts us. They're surmountable once you identify them. That's why, will you recognize it when you see it? It's not just memorizing those 8 stuff. And so we did this COPD readmission, and we had a theory that people are readmitted because wrong diagnosis, wrong meds, nobody follows up. 17% of patients were dead in 6 months, so they're end of life, so they should have been sent to palliative care. We had 3 eventually 3 experienced respiratory therapists. We used motivational interview. We had a training manual, standard questionnaire. We had the chess consultants and the RT leadership supervise. We limit the responsiveness days and daytime. We have a training manual. It's inpatient only, bedside. We have a disease registry. This is what we were intervening. And we were basing it on a lot of guidelines. Our readmission rate for COPD went from 18 to 8%. So that's why we did a collaborative network when we tried to teach 17 other healthcare sites. And a lot of the problems I'm citing are because not all healthcare organizations are the same. And some of the problems that they encountered, I have cited. For example, one organization joined, but then their CEO had a different direction and they were not resourced, so they couldn't do it. One organization was so properly resourced, they kept doing the value stream, they never implemented. 2 years later, they're still at the drawing board. Beautiful drawing board. And so some of the variances, we didn't do checklists, we did motivational interview. If the patient says, I don't want to stop smoking, you stop there. You say, why? What's going on? You ask the patient, what would you like us to help you with? You don't set the goal. It says, we don't want you to come back. No, you use a patient-centered approach so that you are answering the need of the patient, not the need of you to cut costs and make sure you don't get penalized by Medicare. I mean, it's nice if you do that too. And so human resource, this is from Jack Welch. There's a type A. They have passion. They have fire in their belly. No matter where you throw them, they'll float. A good organization will work on B. These are the people who have the potential to become A's. This is where the nurturing is. This is the bottom 10 percentile. Sometimes people just don't have what it takes. They weigh you down. They sit in a conference. They're not there to help you solve the problem. They're there to make sure you don't encroach on their privilege. Get rid of them. Kind of scary, right? But look, how can you have a project? How can you have a system when you have barnacles? You can't have barnacles. So we never do academic interviews for clinical skill. My children are in finance. They don't want to do anything with medicine. And they're given cases, they're asked their time, how long it takes them to calculate things. And they look for character, problem solvers. You want tinkerers, people who teach themselves stuff, and interpersonal skills. You may be a diva, you're the great calf person who can do Tavars left and right with your eyes closed. But if you're a jerk, be a jerk in somebody else's backyard. And then professionalism, somebody who shows up late. You don't have respect for other people's time. And so when you look at these conceptual framework, it's doable. It's very, very doable. You guys are in the right place. Tweak a little education, get involved, and you'll get there. That's why it's not an accident why certain organizations are where they are. You know, there's a saying, hundreds, millions of tiny ripples create a tsunami. Be one of those ripples. I am. That's why if you look at this, here are the objectives. It's an overview. I want to empower you. I want to encourage you. And we talked briefly about these things. It's not to overwhelm you, but to show you the context wherein these are applicable. And in the end, I hope that some of you will go down this pathway and find yourself in joy, because it's all about joy. Seeing patients, being able to sustain it, that's joy. Rather than have a manager there, Dr. Lim, you took 56 minutes to do this case. I mean, that's not joy. That's oppression. Thank you for being tolerant